Hi, my name is Krina Patel. I'm one of the associate professors at MD Anderson Cancer Center, and I'm the section chief of multiple myeloma. And at ASH this year, we had some great follow-up data that was presented just last night for CARTITUDE-4. So again, the study was ciltacabtagene in lines 2 to 4, so earlier line ciltacabtagene versus the standard of care of either DPD or PBD. And of course, the original data showed an amazing PFS and even overall survival data. But yesterday, they showed a little bit about the MRD data, which again, we know MRD depth really matters, and the deeper your response, the better the PFS. And they were able to show that with great to see the MRD data, because I think that really is a biomarker for us for patients who are going to get longer response in PFS and even overall survival. And again, it was in the high 80s for ciltacabtagene and closer to 20s in for the standard of care. So it was a huge difference, which again goes back to what we really care about, the PFS and overall survival data. I think bispecifics are obviously very important as well, just like CAR-T. Unfortunately, most of these studies are done separately. They're similar patient populations. I do think, patients who have high-risk disease, for instance, and need something right away, the bispecifics, you don't want to miss a treatment or a target because you're waiting for CAR-T, right? So I think the fact that bispecifics can be just ordered and given, that's a huge advantage. But I don't think there's been any studies that actually show us sequencing or one or the other is better for certain patient populations. For CAR-T, I think the higher risk is the secondary cancer signal that we've seen. We don't have data from the bispecifics is the problem. I think in the real world, we're actually looking at that and we'll see if there's a difference or not. But I think the bigger issue is the infections with the bispecifics. So if I had a fixed duration bispecific, fantastic, with cevostamab, right? That was the first one that was presented, which was great. But I think there's definitely patients who CAR-T for disease-related or even just logistics-related, they might not be able to do. And so again, that's where the bispecifics come in. But I don't think it's one or the other. I really do think it's both. It's just when. And then the question of combination versus sequencing. I think we have some data with some of the combinations, not necessarily presented at ASH, but hopefully in the near future, we'll have more data. If the combination gets you better MRD, undetectability, and a better PFS and overall survival, makes sense. But maybe really for our high-risk patients where we don't want to wait for a BCMA to stop working, because it usually does stop working less, but then potentially going to a combination for those patients might actually help really improve their survival. So stem cell transplant is sort of our, the last 50 years we've had it for a long time, and I think we're trying to get rid of it. And so I guess CARTITUDE-6, we'll see if it beats transplant. Right, but I think the bigger question is going to be for our high-risk patients. Again, MRD undetectability is great for standard of care, but high risk, you can get MRD undetectable and then you come right back, or still within a year. And so the PFS is usually shorter. So I think those are patients that maybe consolidating after a transplant would actually help, or doing maintenance after CAR-T, depending on how long, I don't know yet, what will take. But I think high-risk patients for sure, there needs to be something added probably for our patients versus standard of care or standard risk. We really want them to be off therapy if we can, because that gives the quality of life goes up. You don't want the tox to add up over time. And so I think exactly for the next line of therapy, we want to make sure their disease doesn't just crumple and now it's resistant to everything. So I think there's really important questions to answer for both different groups. But the risk of relapse is so different in the two, that and what your risk of death is so different, that you have to keep an eye on that population. I think if it does, win in CARTITUDE-5 and 6, I guess the question is, can you do it in smoldering, which there was some data on smoldering. I think we need some more long-term data on that. But, as long as the toxicity is okay, then potentially a one and done for smoldering myeloma could be huge. But again, we have to weigh it out with tox. We also had other studies like Aquila with daratumumab and smoldering that was presented. So, we're making a difference, but I think our goal is that if we're going to treat smoldering patients, we want to cure them, and because they're not having symptoms or having other issues. And so really, I'm excited about some of these novel therapies being tested there.